Welcome everyone. Good morning. I will briefly introduce my topic, which is the importance of social determinants in childhood patients with malignancies. Hi, my name is Miklós Bartók. I'm a PhD student. I'm a pediatric specialist as well. I'm currently working in Kalocsa, which is the part of Kecskemét Central Hospital, and I'm the chief of the infant and pediatric medicine there. My supervisor is Miklós and my SMS is Mark Hernátfi. My vision is to prevent childhood malignancies, and my mission is to identify, and eliminate contributing factors. My two titles and my two projects, which I will briefly introduce you. So the first one is investigating the prevalence of childhood malignancies in different socioeconomic status. We will conduct a systemic review and a meta-analysis. Why is it important? Why childhood malignancies is important? Although this is a rare disease, it has a great healthcare burden because, as you can see in the figure, the leading cause of death by disease among children in the developing countries is childhood cancer. One of the most frequently asked questions is, why is it occur? Why do I have this kind of disease? Unlike adults, this kind of diseases doesn't occur from long-lasting precancerous state, but from a so-called de novo or spontaneous mutations in the genes. And we still don't know the exact role of the environmental factors in their development. So we conduct this meta-analysis because there is a well-adapted idea that people who live in a higher social class have better health and better overall health status than the ones who live in lower social status. And our aim is to looking for connection between socioeconomic status and childhood cancer prevalence. A clinical question is, what is the prevalence of childhood cancer in different socioeconomic status? We use the PEO framework. The P, the population will be children. The E1 is the individual socioeconomic measures like education, income, and occupation of the family or of the parents. And the E2 is the ecological socioeconomic measures. The WHO have the standard criteria called the Human Development Index, which is contributing of three main factors for each country. And also we can measure the neighborhood income, the neighborhood occupational level, the neighborhood employment status, and our outcome will be the prevalence of childhood cancer. Our hypothesis is that the prevalence of childhood cancer is somehow increased in high socioeconomic settings. It will be important if you can establish such a connection because it can be a base or a fundament of further epidemiologic studies, and maybe some interventional strategies can be developed as well. We use 5 domains to search through the literature. The first 2 is about the population, pediatric and cancer. The third and fourth is about the exposures, and the 5th one is about the outcome. I will present you one of my key articles to have some impression about what kind of articles we will dealing with. So these are cohort or case control studies, and they dig out the data from registries, from the cancer registry, the National Cancer Registry database, and also they match it with the parental through the national statistics registries also, and they have these kind of accurate data, but sometimes the limitation is the small sample size. Right now we are finished with the title and approx selection. My co-investigator is Seba. My second topic is the glutamine effect on oral mucositis in childhood cancer patients. It will be a protocol of a multi-center randomized trial. Why is it important? Because during the active chemotherapy, at least 50% of the cancer patient experience at least one episode of mucositis, which is very painful. It decreases the quality of life. It will decrease the nutritional status and maybe postpone the chemotherapy as well. And why glutamine? Because it is inexpensive, easily accessible and applicable, and the current evidence is conflicting about its effectiveness. Our aim is to investigate the benefit on oral mucositis. Our clinical question is, can glutamine change the severity or occurrence of inflammation of the mucous membrane, so-called mucositis, in the mouth or esophagus due to current chemotherapy? The P is the children receiving chemotherapy. The intervention will be the standard oral care plus oral glutamine. The C, the comparison, will be standard oral care plus placebo. And our outcome will be the occurrence and severity of oral mucositis, safety and effectiveness. And our hypothesis is glutamine is an effective prophylactic agent. If we prove it, it will be important because it will decrease the cost of the cancer therapy and their complication. Our inclusion criteria will be patients receiving the first course of methotrexate or 5-fluorouracil, because these are high-risk drugs which can, in the literature, they prove to develop or manifest mucositis in patients. And also we will exclude patients with decreased liver function. The protocol drafting and intervention, so the first one is will be receiving 3 times per day glutamine and standard oral care, which will be written in a which will be written and hand out, and the comparison group will receive only standard care and placebo. Our primary outcome will be the incidence rate of oral mucositis and severity of oral mucositis on the oral mucositis assessment sheet. And our secondary outcomes will be the compare the rate of mucositis-related parenteral nutrition initiation. So briefly, I introduce my 2 topics, which I think it's very important and have a great impact if they prove to be true in the field of childhood malignancies. Thank you for your attention, and my quote is, in life, velocity means very little, acceleration means everything, by Peter Attia. Thank you for your attention.
Okay, this was an interesting presentation, and I think it will be a good project. May I ask you, you mentioned that environmental factors have a decisive role in cancer. And would you try to examine epigenetic mutation, for instance, mutation in the histones, which could influence the development of cancer? Do you plan this, or as for analyzing such literature that I think so?
Well, epigenetics won't be involved in our studies, so we will focus mainly on the socioeconomic measures or socioeconomic status. And if we found out during the literature search that maybe epigenetics is somehow connected with socioeconomic status as well, then we will include it in our meta-analysis.
Okay, not so bad. For instance, socioeconomic situation could be related by the different kind of food additives, which, for instance, could provoke a cancer in the long run. There are such data in the literature, and so I think this would be important. May I ask you another question? That glutamine, you mentioned, the glutamine is also used, for instance, to improve the structure of the small intestinal mucosa, especially in small bowel syndrome. So the oral cavity also belongs somehow, but the mucosa structure is different. But do you know anything
about how the glutamine could make its effect on the mucosa. How would it improve?
Well, during the search, I found that one of the key mechanisms behind glutamine is maybe some antioxidant effect. So if we supplement or give extra amount of glutamine for this child orally, then it may be somehow with these antioxidant effect, it can reduce the effect of these drugs which I mentioned, which is antimetabolites, and because of the basal membrane, their cycle is very fast. Maybe this is the reason it can be effective, that it's eliminating the effect of these antimetabolic drugs in the basal membrane and somehow prevent them to be damaged and causing oral mucositis and apoptosis and this kind of structure damage. Okay. But we still don't know, and that's why I wrote down that the evidence is conflicting, because somehow oral glutamine is preventing, but parenteral glutamine is just increasing the nutritional status, but doesn't have such effect on prevention of the mucositis.
Okay, it was a convincing evidence, so I accept it. Any question from the floor? Question? Yeah.
Congratulations for your great presentation. Since I have a background also in economics, I'm interested on how you calculated or what's the basis of your high social economic status that you mentioned.
The individual level or the area level you mentioned, or both?
Both.
Both. So the individual level is based on the statistical registries. So during the country counting or something like that. So Western countries have such precise data on each member of their society, of their income and of their occupation. So based on that, usually there are 3 or 5 groups of the socioeconomic status, like low, middle, and high, or very low, low, middle, high, very high. So based on their incomes, or which is compared to the GDP, so they divide the nations in these subgroups, and that's how can they say that what kind of socioeconomic status they are belonging. The area level is the Human Development Index, which is a WHO definition, is based on 3 criteria. So the first one is the lifelong estimation of the population. The second one is the years spent in school, so the years of education, and the third one is the per capita income. So these are the 3 mains, and based on these 3 data, they divide the nations. And inside the countries, they use this HDI criteria for counties or for smaller regions. They are calculating these data, and based on the HDI criteria, they are putting their counties or their area into different subgroups, and that's how we want to unify or universalize the data and want to compare them to each other.